So you can see it? Yeah?
Yeah.
Okay.
All right. Okay, we'll begin now. Thank you everyone for joining. Today we have a very interesting webinar for you. Antimicrobial resistance and what's gender and equity got to do with it. And I'm going to introduce our speakers for today shortly. I'm Syeda Tahmina Ahmed. I'm working as a senior research associate at BRAC James B. Grant School of Public Health. And here today with me, we have Dr. Rosie Steege and Katy Davis. I'll give a brief introduction of Dr. Rosie Steege. She is the Gender Equity Lead for GEAR Up. She's a social scientist and health systems researcher. Rosie leads and contributes to the design, development, and delivery of social science themes within large multi-partner, multidisciplinary research consortia. Rosie's research interests focus on supporting inclusive health systems through intersectional analysis in the face of intractable challenges, including AMR. Rosie is passionate about nurturing equitable partnerships for community-led development. And for Katy, Katy is a postdoctoral research associate and social scientist. Her work takes an intersectional approach to issues of gender, inequity, and power in relation to health and environment. With a specific focus on disasters and conflict, she has worked in research partnerships of various scales and has experience using mixed methods and participatory research approaches. So I'll hand over to Rosie, and she can introduce GEAR Up more in details as well as the topic here. So Rosie, go ahead whenever you're ready.
Thanks, Tahmina. And thanks to everyone who's in the organizing committee for inviting us. So Tahmina's done the introductory part for me. So what I'll do is just, hold on, if I can get my slide to move, is I'm going to just start with a bit of scene setting to show why gender and equity are important in AMR. And then I'm going to pass to Tahmina just to give a bit of deep dive insights from Bangladesh as part of the GEAR Up work that we've been doing. And then I'll pass to Katy to just lay out a bit of the way forward for equity in AMR. So GEAR Up is led out of LSTM, but in partnership with James P. Grant Bangladesh. Also, we have LVCT Health Kenya, Seychelles, Zimbabwe, UHAS Ghana, and Herd International in Nepal. And our goal is to support the Fleming Fund country grantees to mainstream gender and equity into their existing plans and structures and catalyze action in this area globally. So, why gender and equity? AMR, you might have heard being referred to as a silent tsunami or a creeping disaster. And it's an issue of urgent global importance. But to date, the approaches to mitigating AMR have been very biomedical, and the social factors have been sidelined. But we do know that the burden of AMR is not distributed equally. Excuse me. So it's not distributed equally globally, but it's also not distributed equally within contexts. And we know that this is because it's driven by and shaped by social and structural inequities. So I'll come to those in a moment, but first I just want to have some key definitions because I'm not sure everyone is coming from a social science background and it might be very helpful. So sex and gender, hopefully you're all familiar with these, but the reason I want to introduce them is because they play different roles in AMR. So when we're talking about sex, we're talking about the biological or chromosomal attributes. And when we're talking about gender, we're talking about socially constructed norms. And they determine the inequalities in power, roles, and relations. And these are dynamic and shifting. And they obviously intersect and interplay with sex, but they both play different roles in AMR, which I'll come to. And the other term that I just want to introduce is intersectionality. So this is the definition from the Oxford Dictionary. So intersectionality is really an analytical framework that explores the interconnected nature of social categories to create overlapping and interdependent systems of discrimination and disadvantage. And so what we're doing with a kind of intersectional lens or an intersectional analysis is really looking at societal processes and structures of power. And so that overlap is really important. So Kimberly Crenshaw, who coined this term back in the early 90s, used it to describe the experiences of Black women in the workplace. So they were different from those of white women, and the experiences were different of other Black men. So it was the intersection of being a woman and being Black that created unique experiences. So that's what we're talking about with intersectionality. So a little bit of a background. So I've talked about, these three things: the sex, the gender, and the intersectional. Way back when Gear Up started, Katy led a scoping review to look at what are the issues of gender in AMR. And actually, we found quite a lot of evidence from just the last 5 years. But it was quite a complex picture. As I say, a lot of overlaps. So for example, if we take susceptibility to infection, which is kind of one of these AMR domains, this can be influenced by the biological aspects. So it can be susceptibility to UTI. Now, biologically, women will have a shorter urethra, so they are more susceptible. Pregnancy can also increase that. Malnutrition can also increase susceptibility, but that one, rather than being just a kind of a biological factor, is also intersects with gender, because if you think that in some contexts, boy children might be favored in a situation where there is not enough food for both. For feeding girls and boys. So you can see how those gender norms and those social norms kind of intersect with the biological factors in that example. And a lot of these intersectional factors also influence susceptibility. So if you think about occupation, there men who are likely to work in mining are at risk of breathing in silica dust. Now, that isn't an exposure, but what it does do is that dust damages the lungs so that you are more susceptible to TB. So it's very complex, right? You've got these intersectional things, these biological things, and these gendered things, and they're all coming together in some of these examples. And there are many other occupational risks. So thinking about roles in animal husbandry, working in an abattoir, caregiving roles, and you can see how those are also gendered in a lot of contexts as well. And I know Tahmina will give an example from Bangladesh about garment workers in a bit to give another example. And then if I just pick one other kind of domain from this visual, antibiotic use. So if we were to take an example of perhaps a woman living in an urban informal settlement, she may not have decision-making power over whether, over treatment of an illness. But even if she did, the cost of diagnostic testing and the cost of accessing a doctor may be prohibitive. And we know that it's really common for people in these settings to access an informal healthcare provider or informal drug seller. And what we also see sometimes is in the absence of kind of social support structures and the absence of holistic care, as is in urban informality, that medicines are often conflated with healthcare. So if you didn't receive medicines, did you really get treated? Did you really get cared for? So I think thinking about the kind of broader structures that antibiotic use, or AMR occurs within, is really, really important. So if I just come on to thinking about AMR as a quintessential One Health issue. So I suspect that many of you are probably familiar with this kind of concept, that One Health considers the interconnections between animals, humans, and the environment. And in so doing, it's really rejecting a reductionist approach, and it's trying to remove boundaries. So there's therefore quite a lot of overlap between the kind of holistic, interconnected approach that One Health requires or demands, and that intersectional feminist theory that we talked about earlier. So those kind of overlapping and interconnected domains. And how those social stratifiers overlap to create those unique experiences. So I would argue that this intersectional lens is actually really critical to the field of AMR and One Health more broadly. But what we've seen is that as a scientific community, we're only just sort of waking up to this, and in other vertical programs, the social sciences have been recognized for a lot longer than it has been in AMR. And so there's still a lot of work to do to integrate social science and other transdisciplinary approaches into AMR and move from the sort of current very biomedical framing towards a biosocial approach. So I just also wanted to share this conceptual model